Welcome to 502 Conversations. I'm Brian Kirby. Remember when we were young and chocolate was good for us? And red wine too, the more the better. And if you drank it while eating a cheese pizza loaded with copious amounts of tomato sauce, your heart would give you snuggles. And not only that, but being slightly overweight was protective. And if you did get sick with any disease, all you needed was the cure-all of vitamin D. Well, Dr. Labos is here to set the record straight. His new book, available to order right now, is Does Coffee Cause Cancer? And 8 More Myths About the Food We Eat. Dr. Labos, thank you for returning. We did have a conversation pre-release, and now you're back to talk a bit more about the book and this year in cardiology. How are you doing today?
I am doing very well, thank you. Thank you for having me back.
Oh, you're welcome, and thank you for coming back. I do have a proper bio on you, all right? So that was just a little joke there, but actually, not really. Dr. Labos is a cardiologist with a degree in epidemiology. He spends most of his time doing things for which he does not get paid, like research, teaching, and appearing on shows such as 502 Conversations. Occasionally, he does find time to practice as a cardiologist so he can pay his rent. He realizes that half of his research findings will be disproved in 5 years. He just doesn't know which half. He writes for the Montreal Gazette and makes regular appearances on CBC radio and TV. He is also the co-host of the Body of Evidence podcast, where he and Jonathan Jerry take a skeptical eye at health claims and look at the body of evidence on a variety of health topics such as obesity and hunger, diabetes, salt, drinking water, generic drugs, fluoride, vaping, GMOs, and so much more. They tell you what's solid, what's iffy, and what's crapola. Okay, Dr. Labos, today you are here to talk to me about your new book, Does Coffee Cause Cancer? And 8 More Myths About the Food We Eat. So before we begin, can you give me a brief synopsis of the book?
So before we get into that, did I understand you correctly that you're not paying me to be here? So am I not making any money off of this interview then? Is that?
I don't know what the royalties are, but I did buy a copy of the book.
Okay.
And I intend to buy 2 more.
Okay, good. Well, that's like a few dollars right there. The book.
A brief synopsis of the book, please.
A brief synopsis of the book. The point of the book, if there is a point, was to try to explain why a lot of the health and food headlines that you've seen in the news are probably wrong, and to explain why food science is so complicated, and to try to debunk a lot of the food myths that permeate our society. And it's doing all of that within the framework of a romantic comedy. So not your typical science book in that there is a narrative. There is a beginning, there's a middle, there's an end, there's a story arc, there is character development, and there's a romantic denouement at the end. But along the way, you are going to learn some math, you're going to learn some science, we're going to debunk some myths, and you're going to learn something about food myths. And so as I like to say in the, I actually think I do say this in the prologue of the book, this isn't a diet book, it's a love story.
I did enjoy the book, as I mentioned before, and I liked the character development, but I also liked the fact that the narrative and the math, it's just right, but if you want more, you provide all the sources, which is awesome, because then you can dig deep and you can say, you can really go and look at these studies like the Framingham Heart Study or Women's Health, whatever it is, you've got it there.
Exactly. And I think that's the point, because for people who just want sort of a casual read, it's there. For people who want the more academic aspect of it, that's there too. You can go and link back to this stuff. And I think this would be useful for people who are interested in the field, for people who are interested in, science and skepticism, to be like, oh, that's very interesting. Oh, let me now get that reference so that I can now debunk stuff when it comes up. Because that was some of the issues I've had with other books, whereas you're reading this book and they start talking to you about something like, let's say, the placebo effect. And you're like, oh, that's really interesting. What's the source for that? I would love to use that in a presentation down the road. And it's very hard to go back to find out where they got a lot of their information. So there's a fairly lengthy appendix at the end where there is a point-by-point, chapter-by-chapter breakdown of where all these relevant studies came from, and the links are there, so people can go to the back of the book and find all the stuff that I'm referencing and have a more formal academic read if they're so inclined.
The setup is you're at you start at an airport, you're traveling to your annual cardiology event, and you meet characters along the way, and you get involved in these discussions with them where you talk about, just conveniently something comes up and you're able to
Yeah.
talk about a myth. I want to ask about the character development. So Jim, Katie, Casey, Alexi, right? I think, is that most of them?
Yeah, you got him. Rufus the dog. Can't forget Rufus the dog.
Okay, Rufus the dog. So I was left wondering, I mean, are they amalgamations of many encounters you've had, or were you thinking of a single specific example, or do you want to protect the innocent and say they're completely made up?
A lot of the characters are based on friends of mine. When I had initially mapped out the book, I had intended for the characters to just be plot devices. They were really just going to voice questions that the reader might have. And so I was really just going to use them to sort of advance the story and make the discussion a little bit more dynamic. And it was only in the writing that I started thinking to myself, oh, I can infuse some personality to these characters. I can give them story arcs. And the first, I mean, if you read the book chronologically, the first chapter was not the first chapter I wrote, but Jim was sort of the first character that I thought of. I had initially, and I'll tell you this, I'd initially almost thought of him in the same way that Ian Fleming had once described James Bond before he started writing the books. He wanted this sort of character that would just sort of like bump into like events. And so I'd initially thought of it that way. I wanted these characters to be sort of bumping into these issues. And as I did it, I ended up rewriting Jim quite a bit. I made him funnier. I made him younger. I made him a lot more almost puppy-like. I'd initially envisaged him as a bit of like a health bro. And I thought I was going to like, take a few jabs at that demographic a bit. Because the initial chapter with Jim is him taking vitamin C. And there's this tendency to be like, I'm going to take vitamins and supplements to boost my immune system. I'm biohacking my body. And then as I wrote the character of Jim, and then as I introduced Katie, and as I thought, isn't it funny if you put these two characters together and watch them interact? I sort of softened them both a little bit, and I made Jim a lot more funny, a lot more innocent. And there were some great lines that I ended up loving for Jim, because one of the conversations that I have with Jim and Katie is about eating meat. And what I liked about that is there's the science of eating meat, which is what we get into in the book. But there's a lot of other aspects to it too. Like people could say, I don't want to eat meat because I care about animals, which is a perfectly valid position to have. And so having those two characters go at each other in that way really allows you to also validate positions people have. Is like, there's an environmental reason to not eat animals. There's an ethical reason not to eat animals. And there's the health stuff, which is what the narrator, what the doctor talks about. But then you have these two other characters giving their points of view. And then you put sort of a romantic tension in that, it becomes even funnier. And you have sort of Jim sort of trying to say, like, if I want to date this girl, how am I going to get around the fact that she doesn't want to eat meat? And so you have lines where the doctor tells Jim, he's like, well, Jim, you could eat salad. And Jim's like, yeah, I do like Cobb salad. And you're like, no, Jim, that has bacon in it. So you were able to sort of put this sort of almost a little bit of naivete in the character of Jim, which made it a lot funnier. And then as I started going through the book, I was able to base a lot of the characters on my friends. And so a lot of the non-medical dialogue was conversations that I had with my friends at various points, and I was able to bounce ideas off of them. And so I hope that there's a certain degree of realism to the conversations, because to some degree, some of these conversations actually happened in one way or another. But I did collapse character. Katie was initially going to be two different characters that had to get merged together just for the narrative of the book to work. So there were certain, there were certain compromises that had to be made just for the sake of the narrative. But I tried to base the characters on real people, and my friends in general seem to like it and seem to enjoy it, and we're relatively pleased that there are now characters based on them in the literary universe.
Relatively pleased. High praise indeed.
Well, one of my friends really did not want to be in there, and I sort of had to work on him a bit. And I said, listen, I need a character who likes wine, who knows his stuff about wine, And, just when people hear your name, they're going to really get like, you sound like somebody who would know something about wine. The editor even said that too. And at the end, he relented and he's like, okay, fine, go ahead. It'll be fine. And I think it's funny.
I did like that part of the book. You mentioned the question of, is something good for you? Is something bad for you? Is it neutral? Regardless, should you do it? So you've got all of that in there. So it works well. I mean, the discussions between the three characters cover all those bases.
Yeah, and I think that's the interesting part, and especially when you get to the issue of red wine, I'll spoil the ending for you. Red wine is not good for you. I mean, it's not. The idea of the whole French paradox, and we go into that in a chapter and explain why it's wrong. But
I have a question about that coming up, so don't spoil it.
Okay. The point is you can still enjoy red wine. You just have to enjoy it and understand what it is, which is an indulgence. It's dessert. And so I think it was interesting to sort of have the characters engaging in a, fancy dinner, and they're drinking wine and they're enjoying themselves because they're going out. And so being able to acknowledge, no, this is not scientifically valid as a health issue, and yet we can still make a conscious decision to enjoy ourselves once in a while, with the inevitable knowledge that as you get older, a late night drinking becomes much harder to tolerate the morning after.
Let me ask you, going a little bit beyond the book, but also the book, I guess I should say. So what myths do you hear colleagues repeat as fact? And do you bother to correct them? Is that okay to ask?
Yeah,
no names.
The red wine myth persists. In fact, just this past summer, I did a whole segment for a news program, or like a news magazine type program here in Montreal, where I am. It's in French, so maybe not accessible to many of your viewers. But they wanted to have this debate between two cardiologists about, is red wine actually good for your heart? And so they had me on as the no argument. And he had this one cardiologist who was vociferously arguing that no, it is good for you. Look at these studies. And I had to sort of explain why not. And we get into this sometimes a little bit subtle statistics in terms of reverse causation and why you see U-shaped curves and all that. And it's a fascinating mathematically, and we can certainly talk about that if you're so inclined. But these myths do exist. I mean, there was a huge debate, and there were these entrenched camps in the medical field about whether salt is good for you or not. The whole, fat versus sugar thing, it's still being debated. And there are people who are almost militantly in one camp versus the other. And one of the other things of the book, I hope people take away from this, is that a lot of these, polarized positions are not really valid, because often everybody's wrong. Everything is just a little bit bad for you, but probably not as bad for you as you think it is. And so hopefully highlighting some of the nuance that exists in the medical literature will explain to people why a lot of these debates are frankly dangerous to the scientific process, but they still exist. And so a lot of these issues with, vitamin C, vitamin D, red wine, meat, and all that, they are still being fiercely debated. These are not resolved issues. And so I hope the book is still timely in the fact that these issues are still going on.
I'm going to come back to the red wine and the French paradox in just a second. But in real life, I'm wondering, because it is a fictional you, I assume, that you're writing about. I don't even know if it's you, actually, but it is kind of you, because it's the first person.
It's a first-person narrative.
Yeah,
so I mean, it's not me in that this is a work of fiction. Like the events of the book never actually happened, as much as I, was inspired by my friends to create some of these characters. But the events of the book never actually happened. I never went to a medical conference and then set off a sequence of events that changed my life and led to a romantic denouement, as it were. So the book is fiction, even though it is written as a first-person narrative. Although, I mean, people who have read it and who know me, who are like, I hear your voice as I'm reading the book. I'm like, yeah, I guess that's fair.
Oh, okay. It's slightly unfortunate, though, about... So any of the good parts are true, and anything somebody doesn't like, well, that's fiction. But
I'll tell you a very funny story before we move on. When I was getting people to review advanced copies of the book, One of my friends one of the people that I know who read the book was like, "Oh, I really love this. Like, tell me, did you ever ask out the real Casey?" And I have to explain, like, no, no, that was just, she was an amalgam. She was largely based on a friend of mine who has her own life. And so, but the people were like, "Oh, is this like actually a real story?" And I was like, no, it's not, unfortunately. It's fiction. And so the great thing about fiction is that you don't have to be bound by the constrictors of reality. Because in reality, you know, as the old saying goes, life doesn't make narrative sense. It's like most of your interactions on a daily basis don't have an ultimate point, but in fiction, you can make that happen. And so you can tie everything up in a nice little bow, which is the advantage of putting the science within a fictional narrative.
In real life, so before we get back to the book, so the real life Christopher Labos. Oh, by the way, when you're talking about people reading the book and liking it, and you're on CBC and you do your own podcast, you're probably starting to wander into that borderline where people read you and they hear you, and so they think they know you, right?
Yeah.
So I can see, when I read the book, I mean, I read it in your voice
Yeah.
because I've heard. We don't know each other. We've only seen each other this way and
Yeah.
corresponded via email. But I read it in your voice, and I thought, oh, I could, hear the nuance there. So I can see the book making that transition even more prevalent in your life. If you go to a book signing and people read the book and say, "Hey, I love this. I love your character," they think the character is you.
Yeah. Yeah, and I think that happens to all authors to some degree, unless you're very clearly writing separate characters. But yeah, I mean, there's always, I think, the tendency to sort of infuse the characters with the author, and I don't think that's necessarily unfair. Somebody once asked Charles Schultz, is the character of Charlie Brown based on you? Because they have the same name, and he said, no, all the characters are me. And so he infused a part of himself into every single one of the characters. And I sort of think of it in that way. I mean, the entire product of the book is me. If I identify with any character, I probably identify closest with, I guess, Rufus the dog, just because he's in the final chapter. And if there's ever a sequel to this book, I'm probably going to develop that character a lot more because he was a great character to write because it's just so funny, at least in my own head. But it happens, right? People will ask me, is like, so in real life, are you kind of like this, like socially awkward, like the character, and kind of clueless about love? And it's like, yeah, probably a little bit, I guess. So, but yeah, I think every one of the characters has a little piece of me in there. And I think that's just part of the writing process. You put a little bit of yourself into the book, but never your whole self. And so making that distinction is always, I think, a little bit interesting.
Well, assuming for the moment that it's more you than fictional,
Mm.
in real life, do you have to distinguish between a good opportunity to comment and a good opportunity to keep your mouth shut and let things go when someone mentions a myth?
Yeah, I mean, this happens all the time because people just love to come up to me, especially now with the book. They're like, "Oh, should we be drinking wine?" And I was like, "Well, I mean, not if you're driving." So there are always opportunities for it. Sometimes the questions are genuine. Sometimes people are like, "Listen," because again, even most physicians, right? Depending on what your specialty is, it's not as if most physicians are sitting there and keeping up to date on all the research that's being done on chocolate. It's like that's outside of their field. If they know anything about the health benefits of chocolate, it's what they're consuming in terms of mass media. So they are no more, you know, uh, involved in reviewing the research than any member of the general public. And so there are sometimes honest, good faith questions being like, "Hey, Chris, the chocolate, is that real? Like, are there actually health benefits?" And then you can actually explain, well, no. And you can bring up the Cosmos study and all sorts of stuff. But some of them are just jokes, right? If you're at a dinner party and they're like, "Hey, Labos, I hear you're against red wine now," which they say as they're pouring glasses of red wine. And so you have to be able to know when it's a valid, question that merits discussion, and when people are just joking. And sometimes people are just joking. And again, a lot of times people do things not because they believe red wine is good for you. They drink red wine because they enjoy it. They eat ice cream because they enjoy it. They eat French fries because they enjoy them. So you are allowed to do things because you enjoy it. What you can't do is believe stuff that is not true. And that's the whole point that I try to get around the book, is like, It's fine to do things that are unhealthy. It's fine to binge watch, the entirety of Lord of the Rings over the course of a day. Just don't go around thinking that it's good for you, because you shouldn't be that sedentary. You should be more active. You should eat healthier. So making that distinction is, I think, the point.
All right, I want to dig into the myths, but something you just mentioned made me want to point something out. So you are, as it says in your bio, you're a cardiologist and an epidemiologist. So
Yeah.
epidemiology, population level disease, not the individual level as a cardiologist. So and a lot of training in statistics and studies and how to design a study, how to read a study. So that is extra and beyond training than you get as a regular doctor. And
Yeah.
so doctors are super smart people in their specialty, but again, epidemiology is yet another specialty that is a finessing
Yeah.
of the research and the ability to interpret these studies.
Right. And there are different types of doctors. I mean, some doctors are clinicians and they are there to treat patients. So they are treating the patient directly in front of them. Some of them are medical doctors, some of them are surgical doctors that perform procedures. And then you have other doctors who just teach, and you have other doctors who just do research. So you can't see all doctors as being the same, because they are different and they should be different. You need different people in different roles. And so the reason why I did a master's degree in epidemiology after I finished my cardiology training was because I wanted to do research. I wanted to understand the research field better. And I didn't have the statistical background with just my clinical training. And I think one of the problems we have is that we expect physicians to do research without giving them the proper research training and background. And increasingly, a lot of the research that we do is statistical. It is population level epidemiology stuff. There's obviously different types of research. You might be doing like wet lab research where you're experimenting on cell cultures and doing that type of stuff, or you're experimenting on animals. And that's obviously a completely different thing. But a lot of the clinical research we do is really the analysis of patient data. And we don't always give physicians the statistical training that they need. I went and I did it, but that was extra training I had to do. It wasn't incorporated into the medical curriculum. And I think it should be. Whether that will happen or not remains to be seen. My hope is that with the passage of time, people will come to appreciate how important this stuff is and make it part of regular medical school curriculum.
All right, let's talk about the myths. So the myths are 9 myths in the book. Vitamin C
Yeah.
fights the common. Do you mind if I mention them all?
No, go ahead.
All right, so vitamin C fights the common cold. Hot dogs are as bad as cigarettes. Some salt is good for you. Coffee causes cancer. Red wine is good for your heart. Chocolate is health food. Breakfast is the most important meal of the day. Caffeine can trigger heart attacks. Vitamin D is the cure for everything. Those are the chapters in the book, all of them myths that you delve into. And I want to talk about one specifically that you have brought up already. So red wine and the French paradox and the alcohol U-shaped curve. All right, so it's holiday time. You're going to hear those things. People will use those as excuses to indulge, right?
Yeah.
Lightly as excuses. I don't mean it in a serious way, but people say, oh, red wine's good for you. Let's take another glass. So define the U-shaped curve and the paradox and what happened there.
So a U-shaped curve, as I will trace out with my finger now, looks like a U. So basically what happens is you have a certain risk of cardiovascular disease. The risk starts to go down as you drink more, and then it starts to go up as you drink a lot more. So the highest risk is the people who drink a lot and the people who drink zero, with the lowest cardiovascular risk being for the people who drink a little bit. And that is something that people repeat many times, saying that a little bit of alcohol is good for you, that it's protective for your heart. And so it's sometimes called a J-shaped curve or a U-shaped curve. And it's the idea that it's not linear, it's not straight. Because if alcohol was purely bad for you, you would expect that the more you drank, the worse it became. But when you analyze data and you see a U-shaped curve, that suggests that a little bit of alcohol is actually protective. And this is the data that has fueled the myth that alcohol is good for your heart, a myth that was made a lot, that was popularized at least in North America after Morley Safer did a story on 60 Minutes about the French paradox, which was purported to explain why heart disease rates were lower in France than they were in America, even though the French ate more fatty food and smoked more and had a number of other potentially negative cardiac risk factors in their population. So that's the myth. That's what the data shows. Understanding why the U-shaped association exists is mathematically very fascinating. There's a few factors that play into it, but the biggest and probably the simplest one is the idea of reverse causation. And reverse causation goes something like this. The people who drink zero alcohol and who are at higher cardiovascular risk probably drink zero alcohol for a reason. They probably used to drink and then quit, or were told by their doctor, don't drink alcohol because it increases your blood pressure, it has a lot of sugar in it, it's not that good for you. They may have developed cancer, they may have developed, liver disease. So there's probably a reason why these people are not drinking alcohol, because most people drink some alcohol. Some people drink zero for cultural, religious reasons, what have you. But most people drink some alcohol some of the time. So if you have somebody who reports zero alcohol intake, there's probably a reason for that. So it's not that the zero alcohol intake is causing disease. It's that the people who are sick drink zero alcohol. So you've reversed the causation. You've gone from A causing B to B causing A. And there's a few different terms for that in the statistical literature. It's also referred to as the protopathic bias. There's a few sort of variants of it. But it basically happens when you take a cross-section of a population and don't account for the fact that things change over time. And yes, maybe somebody's not drinking alcohol now, but they used to drink alcohol in the past. And so not having that time varying exposure is the reason why these studies show this U-shaped association, when if you account for that, you can eliminate a lot of that statistical artifact and realize that, no, it is pretty linear, all things considered, in terms of the risk of drinking alcohol.
You can find data to suggest it, but once you delve into the data, you see that, people aren't actually, they don't have a they don't have a shorter survival rate due to the fact that they're not drinking. It's because they were sick with something else. And
exactly,
that seems like something they could account for in the study, though.
Well, it's actually not that easy, to be honest with you, because it would be very easy for us to sit back here and be like, oh, these studies are terrible.
That's my job.
Yeah.
Sorry.
Analyzing data is actually a lot more complicated than people realize it is. And it's when I supervise students, which I do occasionally, when they're analyzing data, I always like to have them analyze the data themselves rather than just like farm it out to a biostatistician. Because I think there's a value in you working with the data yourself, and for you to realize that a lot of the decisions that you have to make are really just arbitrary. You just have to make an arbitrary decision. Do you want to take this data and lump it into category A or category B? If you have people who are ex-smokers, do you want to treat them as active smokers or former smokers, or are they their own category? There is no inherently right or wrong answer, but the choices you make can influence what the outcome of the data is. So you have to be smart. You have to think about it. Sometimes you have to look at things from different perspectives and see if the results change based on the decisions you make. And that is a significant finding. So, there is no right or wrong way to analyze data. There's just a more careful and less careful way to analyze data. And I think that's the problem that we get into. People will just analyze something, get the answer they want, and be satisfied with that, and not entertain the possibilities like, oh, if I analyze the data this way, I show that red wine is protective. I analyze the data this way, I show it's harmful. Maybe that means that there's no real major effect here at all if the outcomes can be so arbitrary. And that's, I think, a nuance that a lot of times is lost, because a lot of people will, my clinical colleagues who want to do research will, often gather a data set. They'll ask for my help and analyze the data, and I'm happy to do it when they're friends of mine. And they say, look, well, just tell me what the answer is. I'm like, well, that's not the right way to approach it, because the answer can almost be anything you want it to be. It's the process that matters. And that's the point I try to instill in the students, that it's the process that's almost more important than the final result, because the decisions you make when you're framing the data are going to determine what the outcome is going to be.
Perhaps you have foreshadowed, if we have time, when you say the answer can be almost anything. if you, depending on how you look at it. I'm paraphrasing what you just said, but that
Yeah.
may come up again later in the conversation if we get to vitamin D studies.
Yeah.
Going from the French paradox, and actually in real life, you had this debate with another cardiologist about it. So at one point in the book, I guess I'll call it the fictional you, is speaking with your colleague Alexei about, I don't know if you call them redevelopments, but disproved research in medicine
Yeah.
during the 30 years that you've known each other. And he remarks to you, it makes you wonder if 30 years from now, a couple of doctors are going to be sitting here making fun of the bonkers stuff we're doing. All right.
Yeah.
But
Yeah.
when you write that, you're not writing about bonkers stuff you read or hear about in the news. You mean information and knowledge from well-designed, legitimate, controlled studies that still turns out to be inaccurate, right?
Yeah.
So in the past 30 years, I mean, what's been shown incorrect that stunned you, that you actually had adhered to, and then something came up 20 years in and you had to rethink it, and really it was unpleasant
well,
experience for you?
Yeah, I mean, I like to pretend that I'm not that old, and so I like to say that I haven't been around long enough for anything to be like completely off kilt.
Well,
In
you said
terms of
30 years
new
in the
research.
book, so I went with it. I don't know what it would be then. The past 12 years, has anything changed
Yeah.
that you've been stunned?
Well, there have. I mean, I'll give you an example. One of the things that we used to do, um, for every patient who came in who got a radiology scan, who got a CT or anything that required IV contrast, we used to give them a medication called Mucomist, which was N-acetylcysteine. And it was supposedly supposed to protect their kidneys so that it wasn't affected by the contrast, and it was because it had antioxidants in it that would harvest the free radicals. Nobody really understood how it worked, but you had some data showing that it was beneficial, and so it was routinely used. Like every patient who came in, they got Mucomist for renal protection prior to a radiology scan. And I mean, I don't know how many millions of dollars were spent on this. It could be billions if you factor in both Canada and the US and the amount of time that it was used. And it was ultimately shown not to be useful. And the reason why is a very complex question, maybe something for the sequel at some point. But it's shocking to me that we did this routinely, and now it's not done anymore. And you speak to some of the new students, they have no idea what this is. They've never heard of it. It's like ancient history to them, even though it was 10 years basically. So there are these medical reversals all the time. There's an old joke that, beta blockers, a very common blood pressure medication. It used to be that if you gave that to a patient with heart failure, you would be kicked out of the medical program. And now it's standard of care because there has been research showing that when you give beta blockers that slow the heart rate down, rather than weakening the heart muscle, which is what a lot of people used to think, it actually slows the heart rate down to the point where the heart needs less oxygen and becomes a little bit more efficient in its functioning. So it's actually beneficial. So there are these developments and these changes. And the question becomes, are you willing to adapt and change to them? And some people are, and some people aren't.
You're making me wonder. I now see a cardiologist, and it's part of a practice where I think there are 4 or 5 there. And now you've got me wondering, listen, if I got all 4 or 5 of them into a room and asked them the same question, am I going to get the same answer and the same care? I'll get the same care, I'm sure. But am I going to get the same answer? Do they work in a consensus?
I think they will work in a consensus for probably about like 90% of what's out there. And when you get disagreements, and when you get into them, because we do have these issues of like debates at medical conferences, right? And I'm writing an article now about salt, about this whole debate about, is it that sodium is bad for you, or is it that potassium is good for you? So that's probably going to go live in January. I'm writing this for Medscape, which is the medical website where we write scientific articles sometimes. And so it's interesting to have this debate, and you would think it's going to be this very sort of polarized thing. But the reality is, when you actually get the people in the room and you have them debate it out, it becomes very much a question of emphasis. Like, what is the most effective public policy option? In North America, it's probably a lot easier to remove sodium from pre-processed foods than it is to encourage people to eat more potassium. So actual debates, when you actually get them in a non-emotionally charged setting, are really very nuanced and probably not that substantively different. So while there are debates going on in the medical field, it's probably not going to be directly relevant to you and your care, where there is, I think, broadly speaking, fairly good consensus for the vast majority of issues.
All right, right back to the book. You correct me here if I'm wrong, but population-level disease and prevention studies, so much of the population research, it's observational studies, and it can reveal these associations between certain things, not what a lot of people think of as randomized controlled trials. They may not think of them as that, but they think any study shows causation. Okay, but there's association, and then there are other trials designed to show causation. But specifically from the book, and this is where we're going to go deep. So you write about Mendelian randomization and how it's used to infer causation from observational data. Do you mind talking about that a little bit? And I don't know if you want to compare observation with randomized controlled trials or however you want to set it up, but can you talk about that a little bit? Because it's a fascinating term and topic, I found.
Right. Okay. So very, very briefly, the difference between an observational study and a randomized controlled trial. In an observational study, you're not interfering in people's lives. You're letting people do what they want, and then you look to see if there's a difference between people who drink red wine and people who don't. But the problem with observational research is that the people who drink red wine are going to be different than the people who don't in a variety of different ways, not all of which are easy to adjust for statistically. In a randomized controlled trial, you're taking people and you are telling them, do this or do that. You drink wine, you don't. You take this pill, you take a placebo. And you are randomly allocating people to one group or another. And the advantage of doing that is that because you're randomly assigning people to one group or another, if you have a large enough group of people, by random chance, you should get an equal number of people with high blood pressure in both groups. You should get an equal number of men and women in both groups because you've assigned them randomly. So if randomization works correctly, which it doesn't always, but if randomization works correctly and you have a large enough sample, the baseline characteristics of both groups should be balanced, and that evens out a lot of the baseline differences that can skew observational research. The problem is, it's not always easy to do a randomized trial. You know, people talk about it, it's like, we should do a randomized trial for this. You're like, okay, well, how? You know, like, notwithstanding just the money, sometimes you just can't. Like, how do you randomize somebody to diabetes? Like, if you want to see if diabetes leads to this, how are you going to randomize somebody to diabetes? You can't. You can't make somebody diabetic. You can't go and remove their pancreas just to see what happens if they become diabetic. Because, as I like to remind people, we won World War II, and we now have rules about how medical research is practiced. So we are not allowed to do things. Some things are just not ethically permissible. So how do you study this stuff and get away from observational research? Well, there is a type of study design called Mendelian randomization. And the name Mendelian refers to Gregor Mendel, the monk who first explained the concept of genetic inheritance. Small side note, people have looked back at the data and they find that his data is a little bit too neat, so they think that he fudged his results, which was not atypical for the time, where he sort of like rounded stuff off because he wanted everything to work out cleanly in 2x2 boxes. That being said, largely speaking, his work was where we gained an understanding for the idea of dominant and recessive traits and how genes are passed on from one generation to another, which is one of the great weaknesses of Charles Darwin's theory. Charles Darwin, in his initial publications of The Origin of Species, could not explain how genetic traits were passed on from one generation to the next. And that was one of the main criticisms leveled against Darwin. And there is a story, maybe it's apocryphal, that Gregor Mendel, when he was reading The Origin of Species in his monastery where he served as abbot, had made notations in his copy saying, oh, I can explain this using my experiments on pea plants, but then never published any of his work. His work was only revealed after his death, and that's where he gained notoriety. He never had it during his lifetime. So all that to say, Gregor Mendel, genetics. The idea of a Mendelian randomization study is to use genetics to mimic a randomized trial, because at its core is this idea that when conception happens, when egg meets sperm, that's essentially a random event, because you don't know which egg is going to merge with which sperm to produce an embryo. So you as an individual, me, I'm going to have multiple sperms. Some of them are going to have allele A, some of them are going to have allele B. And so it's essentially a random event, which of those alleles I pass on to the embryo. And so if you have a bunch of individuals and you have their genetic makeup because you've taken blood samples from them and you have it there, you can test for a specific genetic marker. And that's essentially a randomized trial because at conception, it was a coin toss whether you got allele A and allele B. And so if you have a genetic marker that codes for the disease that you're interested in and doesn't affect anything else, you can draw a link between this genetic marker, this disease, and the outcome of interest. The assumption is that you have this linear relationship. And if you don't have that, it breaks down. But I realize it's a very complex topic, but the idea of Mendelian randomization is that you can use genetics to do or to mimic a randomized trial when one is not actually feasible. And that has been used in situations like studying the effects of alcohol, where it's very, very complicated to do a randomized trial where you told people, you drink, you don't. Like, you can easily see how that's not going to go well. But if you had a genetic variant that predicted whether people drink or not, and there are these genetic variants that influence enzymes like alcohol dehydrogenase, which is what you use to metabolize alcohol. So people who have specific mutations in that gene don't drink as much alcohol. So you can use that as a proxy for alcohol intake. You can then make inferences in a pseudo randomized trial setting because nothing predates your genetics, right? So because that was the first event in your lifespan, nothing else that came later is going to influence that. So whether you end up developing diabetes, whether you end up, not exercising, whether you end up making a lot of money because you had rich parents, none of that is going to influence your genetics. And so your genetics essentially become a randomized trial where everything else is balanced. And so if you do Mendelian randomization studies right, and they are complicated mathematically to do right, but if you do a Mendelian randomization study right, you can sometimes use it to be the next best thing to a randomized trial that isn't going to be technically feasible for whatever reason.
Okay. It is interesting. So you may have to correct me here. Maybe I'm way off. Because when I was reading about this and the genetic variants at birth, I do know I have a friend with familial hypercholesteremia. It's high cholesterol at a young age, and one parent with it, I guess you're 50% likely to get it. If it's one parent, if both parents, you're more like 25%. Thinking on that, I was wondering, that's a genetic variant, right? So could that variant be used as a substitution for for exposure to a risk factor? So do they serve as a proxy for someone that's exposed to a medication that raises cholesterol?
Well, yeah. So you could, and again, you can use it a number of different ways. When you have a genetic marker like this, if you had like a huge population of patients and you had genetic markers on all of that, you could separate them out into people who had these genetic markers and those who didn't, under the assumption that the people who had those genetic markers are not going to be different in any other way. It's not going to affect whether they're more likely to be smokers. It's not going to affect whether they're likely to become diabetic. It's not going to affect whether they drink alcohol. If it does, though, if that genetic marker does other things apart from cholesterol, it's no longer valid as a Mendelian randomization study. For Mendelian randomization to work, there has to be no pleiotropy. And pleiotropy is when one thing can act via multiple different mechanisms. Now, there are ways to do this. You can actually test multiple genetic markers, some of which are better or worse than others, and then you can average out the effects across all of them. And that's what a lot of Mendelian randomization studies are. They don't test just one genetic marker, they can test all of them. But in your specific example, you can imagine where it becomes problematic, because if you wanted to use that as a proxy for cholesterol medication, you could, in theory, as long as you were able to demonstrate that it was purely the people being prescribed cholesterol medication were getting it simply because their cholesterol was higher. But there are situations where that could become a little bit messy if it's not as clear cut and simple a path going forward. So Mendelian randomization studies, although they are very popular, a lot of people talk about them, you can't just sort of blindly apply them. There has to be some thought that goes into the fact, am I choosing the correct genetic markers? Is there no pleiotropy? Is this a proper way to actually do it?
And you just made me think of something else too. I mean, if you knew that you had this familial hypocholesterolemia, you might start living a different life at a very young age. You might be sure to avoid smoking. You might not drink. You might just work on your diet. You might exercise a lot more. So then you don't become like the population, I guess.
Yeah, and again, and the other problem is that you would probably never use Mendelian randomization in this particular setting because you could just measure people's cholesterol directly and treat them. So that's actually not a good situation in which you would want to use Mendelian randomization because you could just run a clinical trial, right? You could just take a bunch of people who have familial hypercholesterolemia and then test drug A versus drug B. It becomes interesting where you have these very complex diseases. Let's say there's been a lot of Mendelian randomization studies looking at things like multiple sclerosis. And there's this question like, oh, could you use vitamin D to treat multiple sclerosis because vitamin D is the cure for everything? If you wanted to test that hypothesis without spending millions of dollars to a randomized trial, what you could do is you do a Mendelian randomization study with people who have genetically high vitamin D levels and genetically low vitamin D levels. Now, as long as you're willing to accept the premise that people with genetically low vitamin D levels are not more or less common to get vitamin D supplementation, which is a potentially flawed assumption. But if you assume that those genetic levels are not going to influence whether, they develop autoimmune disease, are not going to affect whether they're exposed to chemical, if you assume that it's just acting in isolation and you see that people with low vitamin D levels are more likely to get multiple sclerosis, that becomes an interesting drug target that you can test later. So you want to use Mendelian randomization to test potential disease states to try to understand what leads to a specific disease, because you can't do a randomized trial where you randomize people to vitamin D deficiency. You just can't artificially bring down somebody's vitamin D level. The only thing that you can do is give them a vitamin D supplement to see if it makes things better. But those types of trials are just very expensive and very, very time consuming. So a Mendelian randomization study, especially if you have all the blood samples already, is relatively easy to do, especially since the cost of genetic sequencing has come down substantially in the past 20 years.
Well, let's talk about one that's right in your ballpark. Or, yeah, I guess that's the right term. I don't know. So this Mendelian randomization study, recent study finding that A-fib and neuroticism are associated. And the headline in the press was, higher neuroticism level tied to incident A-fib, younger age onset. So, of course, I'm thinking, great, here's another thing to worry about, right? So, I know, a little neurotic joke there. But then I read the study. Well, anyway, did you read that? Do you want to talk about that and how it worked in there? And then I'll have a comment maybe.
Yeah, so here's the thing. You can't take Mendelian randomization studies and say just because it's a Mendelian randomization study, it has to be true, in the same way that you can't take a randomized control trial and be like, okay, well, that fixes everything. Randomized controlled trials can be done poorly. Randomization can break down. Blinding can be inadequate. There can be deviations to the study protocol. So randomized controlled trials can fail. And Mendelian randomization studies can fail if you have too much pleiotropy, if you don't have good genetic markers that serve as instrumental variables. There's a lot of things that can make them not work. And so when you have a study like this, without analyzing the actual data, I can't tell you one way or the other whether it's true or not. I think Mendelian randomization studies are most useful when you're testing a very clear pathway that makes sense. Right? If you're going to talk about vitamin D and multiple sclerosis, let's say, if it's true, and it's unclear that it is, but if it is true, you can understand what the pathway is. Vitamin D deficiency is, affecting something in the brain. Okay, I can understand how this works. I don't understand how neuroticism, what is essentially a psychological trait, could contribute to atrial fibrillation, which is a very clear electrical arrhythmia which comes from the pulmonary veins in usually the left atrium. It's a consequence of age. It happens when the atrium is dilated. we have a very clear understanding of the pathophysiology there. So at a surface level, I have a little bit of difficulty understanding what the link is. And if it doesn't make sense conceptually to me, that's when I start thinking to myself, well, has the Mendelian randomization not worked in this circumstance? Was there too much pleiotropy? Were the instrumental variables not appropriate? And that's when you would start thinking to yourselves like, okay, well, what's really going on here? And then the other thing is like, well, how do I use this, right? It's not as if treating neuroticism is going to change the structure of your heart. Or if there is, I don't see how that could possibly happen. So the other sort of point often with research is do research if it's going to be useful, if there's a next step that's going to lead to a process. Just saying that there's a link between neuroticism and atrial fibrillation, well, how is that helpful to anybody? What do you, if you have a problem that you can treat, you should fix it regardless of whether it's ultimately going to lead to atrial fibrillation or not. So the study in and of itself, irrespective of the Mendelian randomization part, doesn't actually make sense to me because I don't see how it's practically useful.
Well, I think the authors were saying that neuroticism causes inflammation. Inflammation is associated with AFib. So if you have more inflammation from neuroticism, then they were positing that mechanism. I'm not speaking or saying it's correct. I'm just saying I think that's what they may have been hinting.
Here's the thing. If you wanted to posit that inflammation was a driver of AFib, which is not outside the realm of possibility, there are better genetic markers that you could use. You could use something called C-reactive protein. And then you could see, okay, are people with higher inflammatory states more likely to develop AFib? That I think is interesting because that then opens you up to a possible therapeutic target, which is, can we give people inflammation that suppress inflammation to treat atrial fibrillation? Now, this has been looked at in the past, and it's probably not going to pan out, to be quite honest with you. But that's a much more specific and honed question, whereas like, I'm looking at this inflammatory marker. I want to look at interleukin-6 to see if it's worthwhile to give an interleukin-6 inhibitor to prevent atrial fibrillation. It probably won't be. But that's where this type of research is actually most useful, not in this sort of what sounds like a more vague sort of research question where you're trying to draw a link between two things that may or may not be related.
Well, and back to the study specifically, this is right in your ballpark. Wheelhouse, that's what I was thinking. Okay, this part's in your wheelhouse though. So I read the study and the hazard ratio is 1.05. And they found that 6% of their 4,000 participants developed AFib. I looked it up in the U.S. What I found was the U.S. population of AFib, it's like 2%, which I thought was low. I don't know. 6%.
Yeah,
but
it varies a lot by age, to be honest with you. Once you get into the older age groups, the incidence of AFib is like something like 40%. Like in people over the age of 80, it's close to half the population. So atrial fibrillation just becomes more and more common with age, and as we have an aging population, we just see more of it, and that's just because of gradual remodeling of the heart with age, where the heart just sort of dilates and changes shape and becomes more prone to these types of arrhythmias.
Well, what I found interesting was at a hazard ratio of 1.05, even at the 6% number, so at the 6% number, you'd expect to see, 6 out of 100, or make it easy, like 60 out of 1,000 normal participants developing AFib. But of 1,000 neurotics, you'd see 63 at 1.05. So it's not, maybe that's a hard number and it's always 1.05, but if you're neurotic and 60 are going to get it anyway, is the 3, what are you going to, is that significant? You know what I'm asking?
Yeah. You're essentially getting to the point of absolute versus relative risk, right? Whereas you can get a relative risk marker, which says, oh, you increase the risk of this happening by 20% or 40% or 60%. But then you see, well, what does that mean in practical terms? Like, how many extra cases are you going to see? And then you realize there's very, very few of them. Hazard ratios are a little bit complicated. I'll just make this point, is that hazard ratios don't often mean what people think they mean. And I get this question, it comes up with Jonathan sometimes in the podcast, like, can you translate a hazard ratio into an absolute risk? And the answer is you can't, because hazard ratios are this very, very complex thing that involves calculus and time to event. And so people ask is like, well, what does this mean? And you're like, well, it means nothing. Like, it's like, and I'll give you a sort of a story. In school, we would sometimes have to like graph out mathematical issues, right? And this is high school, it's not a medical school, but we used to have to graph stuff out. But sometimes you get these complex formulas that are multi-dimensional calculus. Somebody said, well, how do we graph this? And the teacher said, just because you can't graph something doesn't make it untrue or unimportant. And so this is the problem, like hazard ratios, just because you can't explain them in terms of absolute risk doesn't mean they're not important. They are very useful, and they are a very useful statistical tool. But their one drawback is for the person who's like, well, tell me what this means to me. How likely am I to get atrial fibrillation or cancer or whatever? You really can't. The point of using that statistical metric is to examine the association between two things that can also change with time. So it's not like at a single time point inflection. And that is useful research-wise, but it requires you as an individual to be like, okay, this is true in the research perspective. Does this actually mean anything clinically? And that is not always a step that everybody takes. So you're right. I mean, if your goal was to avoid atrial fibrillation, the best thing you could do is not age. So my recommendation to you is to not get old, and then you'll probably never get atrial fibrillation. But if you persist in getting old, despite my advice, then the things that are going to be most important is controlling your risk factors like high blood pressure, diabetes, and alcohol intake. Alcohol intake has shown to be a big trigger of atrial fibrillation. So I'm not sure how important neuroticism would be, even if you accept the premise of this one study, which is somewhat dubious.
And I think neuroticism, as you sort of, it's a vague definition, especially in this study. It was self-evaluated using an online questionnaire, so who knows? And I guess I'll say mea culpa there. Yeah, I guess I did jump from hazard ratio to absolute risk, but I've seen that, some studies I read where they'll switch from hazard ratio to relative risk in the same sentence. And I think, what are we talking about? Which one are we talking about here? Because now I'm all confused. And I just did it myself. No.
Yeah, and they're not the same thing.
And neither is odds ratio. So
no. Hazard ratios, risk ratios, odds ratios are three very different things, and they are often used interchangeably, and they should not be.
And I'm more used to relative risk and odds ratio. The hazard ratio, that's a little slippery for me, like you said. All right, let's talk this year in cardiology. You are a cardiologist. Orbita 2, the new big thing. It came out, in November or October of this year at the American Heart Association. They had this Orbita 2 study, which or report, I guess, which I found the reporting on it kind of interesting, which I'll mention in a minute. But do you want to talk about Orbita 1 and Orbita 2 and perhaps why there was an Orbita 2?
So Orbita 1 was a fascinating trial for people who never heard of it.
Well, let's wait. If I hope people saw our first show where we did mention it at the end. So Orbita 2 conveniently is sort of a follow-up to our last discussion. Okay, go ahead.
Right. Okay, so I'll just remind people. So Orbita 1 was a study a few years out now that tested angioplasty, PCI, so going in and opening up a blocked artery, versus placebo, basically a placebo sham control. And what they found is that in people who had optimal medical therapy, going and unblocking the arteries didn't actually make them feel any better. Like the angina symptoms did not get better. And this, was a big hullabaloo in the community because opening up blocked artery is very common in cardiology, very lucrative for some people. And so if you were going to propose the idea that angioplasty was just a giant placebo response, I'm not sure there would have been rioting in the streets, but it would have been close.
And it's specified for stable angina, right?
For stable angina, right? Not for getting, not for when you're having a heart attack. That's a completely different animal. And I wrote about Orbita 1 when it came out. And the first line of the article was like, it's very important to unblock an artery if you're having a heart attack, but if you have stable angina, and I started talking about it. And then I got so many emails about Orbita 1. They're like, you're scaring people. I'm like, I was the amount of emails I got were just hilarious. And people leveled some criticism against Orbita 1. They said it was a small trial, which it was, but just being small in and of itself doesn't invalidate it. But this Orbita 2 is the follow-up study to that, where they sort of did the same type of trial, patients with stable angina, but on virtually no medical therapy. Again, as a placebo sham control. And what they found is that there was an improvement in angina scores. Not complete resolution, because something about 60% of the people still had angina after they got their procedure done. But it did prove that angioplasty is not hocus pocus, right? By unblocking the artery, you do reduce angina. You just don't make it go away. So my interpretation of Orbita 1 and Orbita 2 together is that you should start with medical therapy, and then if you have residual symptoms, you do angioplasty then to treat the angina. To use it as a first-line therapy in the absence of medication is not going to be that effective for the majority of people. And both of these studies were about treating symptoms, not about preventing heart attacks, not about preventing death, which I feel has been pretty much established in the medical literature now. You don't unblock stable coronary arteries to prevent heart attacks, because you won't. You unblock arteries to treat symptoms. So if you have a patient who's symptom-free and you find the blocked artery randomly because you did a stress test for some obscure reason, you don't necessarily need to go unblock that artery, because you're not going to make an asymptomatic patient feel any better. And that's, I think, an important point. And this is very hard for people to conceptualize, because a lot of people think, I have a blocked artery, I need to go get it opened up, I can't live like this. You do not prevent heart attacks by unblocking arteries. You treat symptoms by unblocking arteries. And so if you have symptoms despite medical therapy, yeah, I think it's reasonable to go for an angioplasty. I send people for angioplasties for those reasons all the time. But I would make the argument you should try treating them with medicine first, because I think most people would hopefully prefer to take medication rather than go for an invasive procedure. But if there are people who are like, no, I hate taking medication, send me to the cath lab, it's a bit of a weird point of view, not one that I necessarily understand, but it is a valid choice that somebody can make if they understand all the risks and the benefits, to opt for a procedure if it means maybe not having to take as much medication.
Let me ask you a question about the two studies based on your epidemiology and your research and your statistics and the expertise there. I mean, were they really, there were differences in the studies, right? So Orbita 1, I think it was, it demonstrated one blockage, right? Where Orbita 2, it was at least one, maybe more, and demonstrated angina and evidence of lack of blood flow, right? And another, it was like 12 weeks long instead of 6 weeks.
Yeah.
So they were kind of had different endpoints and participants. Is that incorrect?
Yeah, they were a little bit different. When Orbita 1 was actually done, they were actually very limited by the size and scope of it, because the ethics board, again, felt that it was inappropriate to not send patients for an angiogram. So basically, they had 6 weeks, then everybody went for an angiogram afterwards anyways. So all they did was delay the angiogram for 6 weeks in the control group. So they were very limited in what they could do. And again, we talk about doing randomized trials as if they're easy. This probably cost millions of dollars, and probably took, it did take years. It took years to do. So we shouldn't be, I'm struggling for the right word. We shouldn't think as if doing randomized trials is something you can just slap your fingers and make it happen. The people involved designed the best trial they could. There were differences between the two groups, and they were testing a very, very specific thing. In Orbita 2, they were testing off medical therapy. If you send somebody for an angioplasty, will they feel better? And the answer is yes, they will. But again, I would make the point that, well, I would treat them with medicine first and then decide if you want to send them for a more invasive procedure, because there are risks to an invasive procedure. Not everybody's going to have the same value preferences that I have. Some people will happily take a certain upfront risk if it means not having to take medication. For some people, taking daily medications is a burdensome thing that they cannot tolerate, whereas for other people, they're like, no, I would obviously rather take medication than do an invasive procedure. So It tested a very, very specific question, which is angioplasty a pure placebo? I think it's clear that it isn't. I don't never truly believe that it was. Is angioplasty a pure placebo? No, but it didn't test what's the correct algorithm going forward, because that's a clinical judgment. That's not really something that you could do in a randomized trial type setting. You could, but it would be very hard to keep people in the protocol you've set out for them. You would have probably too many deviations as people got better, got worse, changed their minds, stuff like that.
I know it, well, from reading the reports on it, it was very welcome news at the American Heart Association conference. Like, it was met with a sustained ovation, they said. So it was
Yeah, I mean,
made the cardiologists or the surgeons or somebody very happy.
well, I mean, I'll be honest with you. Like, have you ever been to a concert where it didn't end in a standing ovation? Like, don't people just at the end of a play, doesn't everybody just stand up? Like,
Well, yeah, I think that'd be odd for a conference, though.
but I don't know. I see this all the time. Like, oh my God, people cheered. I'm like, no, they applauded politely
Okay.
because that's when you do when you're in a conference. Like, again, maybe I'm just too cynical, but was it met with play? Sure. I mean, look, there were obviously going to be major. If you somehow said doing angioplasties don't matter, stop them altogether, which of course nobody would do because you still need them. People are still having heart attacks. You still have to unblock an artery when someone's having a heart attack. But if you said that treating stable angina with angioplasties is not beneficial, especially in the U.S., where the lucrative aspect of this might be driving some of this. That's that's as far as I'll go in my social commentary. Yeah, there would have been major financial penalties for large segments of the profession, and I think a lot of people were relieved that they can keep doing what they're doing. That being said, I do think that angioplasties are probably overused. And when we look at reports, again, maybe more so in the U.S. than in Canada, where our socialized healthcare system has certain restraints put on cost and unnecessary procedures. Yeah, there probably is a little bit of overtesting, but I think certainly people were pleased to know that what they were doing was not hocus pocus, because that would have hurt a lot of people in terms of the bottom line.
I mean, in reading the study, you can comment on this part of it too. I'm not sure what the word is. I felt kind of bad for the sham participants because they took all the risk without the hope of benefit, but they didn't know it, right? So they stopped their anti-anginal meds. They had the angioplasty without a stent. They were sedated. They spent 12 weeks without the meds, reporting episodes of angina to compare it to the others. And also, I mean, you can't discount the fact that they took the risk of hospital-acquired infections, right? Because they were actually sedated. And I think if I read it right, they were randomized after sedation. So nobody knew until that point. So they'd gone through all this. So I'm not sure if they were, I felt bad for them, and they were very, I don't know if brave is the right word, but they were very agreeable to take such a, to go through all of that without the hope of benefit.
Well, and here's the thing. I mean, people who enroll in clinical trials need to be commended for the sacrifice they are making.
That's the word.
Yeah, it's not easy. It's not easy. And I mean, we have a big problem in that it's harder and harder to run clinical trials in North America and Europe because a lot of people just don't want to do it, right? People listening to us now would be like, well, I would never agree to that. Why should I stick my neck out and put myself through this? I don't want to, which is understandable. But it does mean that it becomes harder and harder to run clinical trials. And so you have pharmaceutical companies running clinical trials in Asia, Africa, other parts of the world, which, you sort of wonder sometimes about the degree of oversight that's happening in some of these countries. And there have been examples. There was one study, I think it was the TopCat trial, where they had these very, very discrepant results. And when they looked at them, they found that the way the study was done in Russia was radically different than how the study was done in North America. And that's just because, they had very little oversight of what was happening in Russia. And, a lot of the people that were hired to run the trial were not giving out the right medications. A lot of people who were supposed to get the study medication didn't actually get it. And that's a problem. Like, if we want well-designed clinical trials, we're kind of going to have to do them here where we can monitor things properly. But that requires people to volunteer for them. And if people don't want to volunteer for clinical trials, it's going to become really hard to test whether drug A is better than drug B.
I just wanted to follow that up with immediately after that, within a couple of weeks, I think this Lone Institute Hospital Index 2023 report came out that reported on stent
Yeah.
overuse in U.S. hospitals. They found like over 250,000. Well, however they defined it, 250,000 were unnecessary, right? But it's
Yeah, and this, I mean, it's not even that, just not just reports. I mean, doctors have gone to prison for Medicare fraud
ooh,
over the unnecessary deployment of stents. Like this has happened. Like people, have been convicted of like, I don't know if it's a felony. I'm pretty sure it's a felony. Like
fraud.
they've been convicted of crimes because basically, especially when you're talking about Medicare, if you put in a stent that it's not necessary and bill Medicare, you've essentially taken money from an insurance company, which is Medicare, for a procedure the patient didn't need. That is ethically questionable. Medically, that could, make you subject to, professional ramifications in terms of losing your license. But you've just committed fraud because you've billed an insurance company untruthfully. And so unnecessary medical procedures are not, theoretical or philosophical arguments. They cost money. They cost the healthcare system money. They cost you money as a taxpayer because you are paying for that through Medicare. So, we can't let people do illegal things. And so if you're performing unnecessary procedures on people, that is very wrong morally, but also very wrong legally. And part of the goal of evidence-based medicine is to reduce unnecessary testing, because one of the issue, and this is true of both Canada and the US, we overspend. There's a lot of stuff that we do in healthcare that is medically unnecessary. And if we stopped doing it, the patients would be just as fine, and we would be saving a lot of money for a system that is going to be under increasing economic pressure as our population continues to age.
I'll just briefly add, anyone can look this up, Lone Hospital Index, stent overuse, that'll get you there. It was just surprising that of the top 10 hospitals, 3 were in one state, right? With over 50% of stents inappropriately used is what they came up with, which is just shocking. Because it's not only the fraud, but as you hinted at, I mean, you're putting a person through this that doesn't need it.
Yeah. And again, I mean, I hate to say it, but it's being driven by the fact that these procedures are very lucrative. And so if you have a financial incentive to do something, you're not always going to put the patients first. And that is really, really unfortunate.
The first author on Orbiter 2 disclosed financial relationships with the but that doesn't necessarily taint the study. All right, so
that doesn't necessarily taint the study. And I mean, again, if you look at studies shouldn't have philosophical underpinnings, but the people there in Orbiter 1 and Orbiter 2 really were looking at this in the sense, like, they were prepared to say that there was, that they were willing to question the very nature of angioplasty. So I not knowing them, I don't think that there was any sort of incentive to sort of suppress the truth. If anything, quite the opposite. And they got a lot of flack from the rest of the community for suggesting that angioplasty was maybe not that effective if patients are otherwise well treated medically. So, I mean, they were prepared to question something. And, the unfortunate reality is that a lot of physicians have ties with the pharmaceutical industry. I don't take money from the pharmaceutical industry because I do a lot of this public facing science communication. It doesn't, again, most people are not like me, which is probably a good thing. But just the presence of a financial conflict of interest in and of itself is not a sign that the study was wrong. Where it becomes problematic is, did a company sponsor the trial? Were they actually financially driving the trial? And did they have access to the data? And that is a big thing. That happens more often than we realize, where the sponsor, usually a pharmaceutical company, doesn't just fund the trial. They collected the data and analyzed the data before handing it back to the main researchers. And that to me is shocking. And it should be shocking to most people, because my question then as a researcher is like, well, why were you there? If you had a third party collect and analyze the data for you, what were you there for? To put the good housekeeping seal of approval on the report? Like, what did you do? I mean, I listen, and I'm not expecting people from Boston to travel to Russia to run a trial if that's where it's being run, right? You obviously have to outsource some of the mechanics of it, but I don't think sponsors and pharmaceutical companies should be collecting the data and analyzing the data of all things. That I think that is a situation in which you could really, call into question the results of a study. But somebody who just, gave a talk that was sponsored by a company at some point in the past, but that company had nothing to do with the current trial, that is more understandable, if not forgivable, even though I wish we lived in a world where we didn't have this sometimes very insidious relationship between industry and the medical field.
Well, a cynic might say that the reason they're there to collect and analyze the data is so that if it's not going their way, they can just kill it before
And
it gets
sadly,
published.
there have been many instances where that has happened. There was a famous study called Study 329, which looked at antidepressants in adolescents. I wrote an article about this for Maclean's a few years back. You can probably find it online if you search, Christopher Labos Maclean's antidepressants. Maclean's is a magazine here in Canada. And that's exactly what happened. The pharmaceutical company held the data. There were signs that there was a signal for increased suicidality when antidepressants were given to young people. And they thwarted efforts for researchers to gain access to the data for years and really tried to suppress the potential suicide link that was there by relabeling the suicidality as like aberrant behavior or just lumping it into just neurological side effects. The way they analyzed the data obscured that potential danger, and it took years for researchers to actually get the raw data, reanalyze it, and show that the suicide risk was there. So there is a very real danger in allowing a private company that has a vested interest in their product to analyze data specifically as it relates to safety and efficacy of their own product.
All right, let's get some good news. What's good about this year in cardiology? Maybe some highlights from your own conference.
What's good? The world didn't end, so that always pleases me. You watch the news and you sometimes think that we're one step away from Armageddon at any given moment. So the world didn't end. I'm very pleased. There's been a few interesting trials. Orbited 2 has come out. There's a lot of new work coming out, a lot of drugs in the pipeline for cholesterol treatments, which is fascinating because prior to 1990, there was basically nothing that was good for cholesterol. And now 30 years later, we have this plethora of medications to the point where we're almost getting to the point where you almost don't even need to take oral pills for your medication anymore. There are a lot of medications that are injections, and I know people don't like needles, but there are like weekly injections, there are like monthly injections, and now we're getting to the point where there are every 6-month injections. And so for a lot of people to be like, well, rather than taking a pill every day, taking a shot every 6 months, I'm like, that's potentially much more interesting. So there's a lot of new developments coming down, and we're never going to run out of research. There's always going to be new developments. The real issue is going to be the cost, and a lot of these new medications are just so expensive that I'm not quite sure how we're going to square that circle in terms of paying for healthcare, especially as we have an older population that's just getting sicker and living longer.
Back to the book, Vitamin D Cures Everything. It's one of my favorite topics, okay. And I sent you this study just to look at before this conversation, vitamin D and cancer. It seems to be a perennial topic for journals, if ever there was one, vitamin D and cancer. I could almost attribute that probably to one person, but I won't. So this study was the effect of, I'll name it, the effect of vitamin D supplements on relapse or death in a P53 immunoreactive subgroup with digestive tract cancer. Very specific there, okay. But the study was an analysis of a previous study that actually didn't show results. So they went back and looked at this study and they subgrouped it, and then they had to subgroup the subgroup, and then they got positive results. So to me, even without getting into specifics, perhaps you can answer this question. I mean, when you subgroup a subgroup and you find an association, it just sounds like if you look hard enough, you'll find something. I don't know if that's fair or not. You say so.
That's exactly right. I mean, this is exactly the issue of multiple hypothesis testing, whereas you do enough analyses, also called p-hacking, also called salami slicing. There's many different names for it. But it's basically that. It's like you do enough analyses until you find something you like, and that's what you publish. And that is problematic because, every analysis looks good if you ignore the 19 negative ones that came before. So if you don't start out with a question, what's really fascinating is that when you ask the general public, like, how do you think research happens? And they're like, well, researchers start with a question and then they publish the results regardless of what the answer was. And the answer is no. Like, you have to convince a journal to publish your results. And sometimes they will tell you, no, it's boring. So there's this incentive to have new findings that are interesting. So if you do a study where vitamin D does nothing, people are going to be like, yeah, who cares? Whereas if you do a study that shows that vitamin D can help treat cancer, like, oh, this is interesting, people are going to talk about it. People are going to order reprints. Now we'll publish it in our journal. And so there's an incentive to publish positive research, which is a problem because it means that a lot of negative research is going unpublished because nobody finds it interesting. And
But wait, before you go on though, I
Yeah.
mentioned this specific study and a general concept. So could you just clarify if you're speaking generally or if you're talking about this study?
oh, well, both to a certain
Oh,
extent.
okay, good. I just wanted to,
I
don't want
yeah.
anybody to tell me that, okay, go ahead.
Yeah, both to a certain extent. I mean, here it's the issue is that it's not wrong to do secondary analyses, okay? It's not wrong to do exploratory analyses, but we shouldn't see them as causative. If you want to prove that vitamin D treats these types of people, then do a study and design it. That's fine. But the problem is that when you do a study, when you power a study, it's designed to do one analysis. If you do 20 analyses off of that same data set, just by random chance, you are probably going to get a positive result. And that's actually the moral of the first chapter of the book, which is about vitamin C, not vitamin D. But that's the point, is that you can find the positive result if you do enough analyses. And that issue of multiple hypothesis testing can lead us astray, because if you don't power your studies properly for all the questions you want to answer, you're going to get underpowered studies and you might get, results that are wrong just by random chance, not because you did anything wrong, not because you cheated, not because you faked the data. It's just random. Sometimes you get aberrant findings. It's the example that I like to use when I speak to journalists is, have you ever seen a political poll that was just like out to lunch, that was just like completely wrong? Yeah, it happens sometimes. In the same way that a political poll can just be completely wrong because you just had a random selection of people that did not reflect the general population, sometimes the statistical analysis can just be wrong because you just caught a selection of data that was not representative of the whole.
I was left wondering, I wonder how many subgroups they did do and if this was the one they reported. I mean, there's no way to know, but
There's no way to know.
But they did, in this study, they did one subgroup and they found no difference versus placebo. But then when they subgrouped again and adjusted for age and history of cardiovascular disease, they found an association. But then is the association between 5-year relapse and age and cardiovascular disease? Or is it between vitamin D? I mean, so how would you, anyway, subgrouping a subgroup. That's how I kind of thought of this one.
Yeah, it's problematic, but it's common, and that's unfortunate because, again, there's a drive to publish, whereas if you did something along the lines of registered reports, whereas like, we're going to do this study, you get it pre-accepted in a journal, whatever the results are, and you publish that, you now have removed this incentive because your results are published regardless. There's not this need to sort of, gussy them up to make them more interesting. You just publish what it is. But we don't do registered reports in most journals. You have to do the study and then see if the journal will accept it, which is not how most people think science is done, which I find fascinating. Because when you tell people, I have this very controversial idea called registered reports, people are like, isn't that how it's supposed to work? Why is that controversial?
I did find some of the language, maybe this happens more than I know, but just went both ways. So they said, the findings must be considered exploratory, interpreted with caution, although the main results are remarkable. Well, is it remarkable or is it exploratory? Or is that even, and they...
I had a similar interaction with, again, a vitamin D study in ICU patients. That was, and I wrote an article about it, which is like, yeah, another negative vitamin D study. And then the main author contacted me directly. In the paper, they wrote this was a negative study, there's no real, but then they're like, you didn't see our subgroup. This could be a game changer. This is going to change how we treat patients in the ICU. And I was like, Because what you wrote in the paper was that this was an overall negative study with one positive subgroup, likely because they were forced to say that by the editorial team of the journal. But yeah, people listen, when it's your own research, you have this natural tendency to think you've just, won the Nobel Prize. Like you're like, this is the greatest thing that has ever been produced by a human being on planet Earth. How do you not see that? This was years of my blood, sweat, and toil. It is amazing. You need to recognize that and throw me a parade. So we have, and I have this too, we have this own bias towards our own research to think it's greater than it actually is. When, sometimes it's just whatever, right? Sometimes it's just whatever. And it's very hard for you to judge your own research. And people sometimes have this very dichotic interpretation of their own research. Officially, they say what they have to say, but privately, they're like, no, of course this is true. Random chance is something that affects other people. It doesn't affect me. My research, it's true. It's those other guys that are, subject to like confounding and bias and stuff like that.
Well, I find the vitamin D thing out of control. So, because if it were that easy, I mean, forget every other study in the world, just more vitamin D, more vitamin D. So, it's just amazing.
Well, I mean, here's the thing. I mean, we supplement a lot of our food with vitamin D here in Canada. I think the US more and more so, because we've been supplementing our milk with vitamin D for decades. I think the rule in the US is that it's not mandatory, but it's become almost a voluntary supplementation, and it's pretty universal, I think, at this point. Most people are getting vitamin D supplementation. If it prevented cancer, there would be no cancer left in this country because everybody's pretty much getting vitamin D at this point. The vitamin D deficiency is not as common as a lot of people like to claim that it is.
All right, I have a great vitamin D story, but I won't relate it here. Too long. So, Dr. Labos, you just hinted at something as we get to wrap up here. You were talking about publishing a negative study in the paper and being contacted. So, excluding yourself, if you could convince or talk to medical reporters and tell them what the top 3 things they need to educate themselves about or become aware of, when summarizing scientific papers, I mean, what would those 3 things be? Or 2 things or 1 thing? What do you see most concerning, I guess?
I think the first thing would be to sort of impress upon them that not all studies are equal. You often see the health story be like, a new study has shown. It's like, okay, but what type of study was it? Was it an observational study? Was it a randomized trial? Was it properly blinded? So the conduct of the trial is important, and that's often not reported. The other big one is the historical context is often not reported. They will report on this study that happened right now and ignore the 9 studies that came before. If you have a new study that's positive, but you have 9 studies that came before it that were negative, that 10th study isn't groundbreaking, it's an outlier. And so often health news is not put into the proper context, and the inconclusiveness of the field sometimes is not adequately reported. So that's really the big one, is that, to be a little bit more critical about each individual study because they have flaws, but also to look at the general background, right? I mean, there is a lot of negative research on vitamin C in terms of preventing the common cold. If you're going to focus on one study that shows a benefit, maybe you should mention the 20 other studies that showed that it didn't, because that's going to provide an important flavor to the article so that people understand it's like, oh, okay, this is probably just an aberrant study. And that's a problem, because if you're doing an interview and you tell a journalist that, this is really not that big of a study, what ends up happening is they usually just kill the story. They'll be like, okay, well, we won't do a story on it. And that's probably for the best, because it's very hard to write a story. We'd be like, okay, so here's this new study you've never heard of, and this is why you shouldn't care about it. That's a hard hook for a news program. And so the problem with news in general is that we want news to be interesting because you want people to watch it, but it's very hard to get people excited about negative research unless you're debunking something that is widely convinced to be true. Because I'm sure somewhere somebody has done a study that shows that cucumbers don't cause prostate cancer, but no one's going to talk about a study about why cucumbers don't cause prostate cancer, because why would you even bring it up? No one actually believes that right now. And so those studies tend to fly under the radar until you get the one aberrant thing which shows, oh, maybe cucumbers do cause prostate cancer. And you set off this whole maelstrom of coverage, even though it's probably not justified.
All right, there's an obvious joke there about cucumbers and prostate cancer that I shall not
That's for the best.
make. All right. Before we totally wrap up, my wife really loves these medical dramas on TV. I don't like them that much because there's too much drama, I say. 2 minutes relationship building. I'd rather see something happening, which I guess that's something happening. But all right, let me ask you point blank. You can say no comment, you can comment, whatever you want. But I must say there seems to be a lot of time in these hospitals for extracurricular physical activity between doctors and nurses and doctors and staff, et cetera, and always finding time to go to the cloakroom or whatever they call it. Is that accurate, or is that just okay? You don't have that much time.
I mean, I'm sure there have been workplace romances. I'm sure those do happen. Frankly, most people go to work, they want to get out of work as quickly as possible and go home, because most people have lives. I mean, I'm sure there have been workplace romances. I'm sure there have been illicit workplace romances, but they are hardly common. Don't forget, you're also dealing with people with very wide variations of age. If you watch TV, everybody who works in the hospital is between the ages of 20 and 30. The reality is you have people, their entire careers, and people are married and people have other, and the idea that people are hanging around in the hospital afterwards to just chill out with their friends. No, when you're done work, you go home usually as quickly as possible. So yeah, these hospital shows are not like real life. The one show that was probably closest to reality, and I say this to everybody who asks me, was the TV show Scrubs. Because you do form camaraderie and friendships with the people, but if you do see them, you see them outside of work on your own time. You're not hanging around the hospital doing that. And why I liked Scrubs was not only was it a very funny show, and it had an absurdist type of comedy which really appealed to me, the medicine in it was very accurate, because most of the people in it just had like pneumonia and cancer and very run-of-the-mill stuff. And a lot of it was about the interactions and the conflicts between people and patients, often about real emotional and ethical issues, not sort of the absurd romances. There was a romance in the show Scrubs, right? The Turk was married to Carla.
Oh,
and so it's not as if it's unheard
I've only
of.
seen a few episodes.
Oh,
they just
okay.
started dating. Oh.
So, but that's a relationship, and that's fine. Relationships do happen, but when they do happen, they do tend to be, stable, long-term relationships, in the same way that, these sorts of things probably happen at law firms and at, Google. I don't know. I mean, so it's not like Grey's Anatomy or some of these other shows where they get sometimes a little bit absurd. So I do like Scrubs. So I do highly recommend it.
Probably everybody knew the answer to that question, but I thought I would ask it because it just seems so prevalent in these shows. Maybe there's some truth there, but okay. Oh, by the way, now that you've written the book, you want to write a sequel. Do you carry a release with you now for people you meet that warns them that they or part of them could be used for a book? You have them sign a real. Is anybody worried about that? They don't want to talk to you anymore?
No, I mean, most people are more than happy to sort of talk. I mean, again, the people who I talked to were my friends, and we would just be chatting about stuff. And I would tell them that I was, especially when we got into some of the cooking issues, I would speak with a friend of mine who was very big on cooking, and it was, I was like, well, what do you think about this? And so we would have these conversations about cooking, and I would use that to infuse some of the character development in the book. So most times people are more than happy to talk, because in the end, I'm talking with my friends, and I hope, and to some degree, they enjoy the idea that a character is based on them, even though there's really no way to trace back the characters in the book to the real people in life, because there's snippets and flavors of character development, but nothing that could be like really considered an identifiable characteristic.
Plus, I suppose even if it were a bad character and somebody recognized it, it's still them. Hey, look, I'm famous. He used me in the book. Yeah. All right, I kind of jossed with you up front about taking everything good away, but in fairness, the book is great. Does Coffee Cause Cancer and 8 More Myths? You do ease many concerns. So some things go away, like chocolate, red wine, but you do ease many concerns over certain things, like, when hot dogs were touted as being bad as cigarettes, and you point out that there's no need for the average person to waste money on vitamin C, or you can skip breakfast, and don't worry about that cup of coffee giving you a heart attack. So there's good, and there's things to be eased about, and there's things to think about for sure.
Yeah.
And it's fun, it's informative. Oh, and so this is your first foray into publishing for a popular audience, right?
Yeah.
Any words of wisdom for aspiring writers? I mean, how was the process for you?
I mean, listen, you don't write a book to get rich. It takes a lot of time, and the return on investment is not there until you get into, like, John Grisham territory or something. If you want to write a book, You write a book because you have this burning passion to do so, and because you want to essentially create something, because it is a great feeling. The idea to physically hold a book in your hand, to unbox the book when they ship it to you for the first time, is a great feeling. I was with somebody when it happened and they took a picture, and I look back at myself and I was like genuinely smiling in a way that I don't normally do. So it's a great feeling. It's a great emotional journey to go on. Don't set out on the journey because you think you're going to become a millionaire. You might not. Do it because you genuinely love it, because you genuinely want to do it, because you have something you want to say and you want to get that message out there. And if you do that, then the process is going to be emotionally fulfilling and it'll make you feel good about yourself. And if it succeeds, all the much better. Like, I'm always shocked when people are like, "Oh, I want to buy your book." I'm like, "Cool." Like, I would have almost written it. Because here's the thing, you could also, if you wanted to, self-publish a book. Publishing a book, the act of publishing a book, is not that expensive. A standard book like this, if there's no graphics and no color in it, you could probably print a book for somewhere around $5, $6, $7 per volume. I mean, if you just wanted to do it as a vanity project, you could like print the books and give them away as Christmas gifts to people. So, again, do it because you want to do it. Do it because you're proud of your work. Don't do it because you want to make millions of dollars. If you do, so much the better. But do it for you. And then if other people enjoy it, then so much the better.
Well, it's got to help to have a publisher behind you and a publicist.
Yes. Because yes.
That
If you
can't-
want to sell it in bookstores and have, broad publicity, it obviously helps to have a publisher and a publicist and an agent behind you doing all the work. Although a lot of it, you still have to hustle yourself, right? A lot of it is you doing your own sort of hustle for these sort of things. But yeah, it obviously helps to have an institution behind you. But a lot of people, especially if you want to do a memoir for your family, I see a lot of people who want to publish a book about their family history. Nothing stops you from just writing it, going to a printer and publishing the book yourself in a limited run for your family. It's not actually that expensive to do. So if this is something that you want to do as a labor of love, really nothing stops you from doing it, because it's not hard to actually print a book. It's hard to mass market a book to the general public, but you can write it. And if you do going to write a book, actually, I will say, if you want to do it on your own, get a professional editor to go through it and fix a lot of the stuff, because the editing often will save and improve a book drastically.
All right. The book is Does Coffee Cause Cancer? And 8 More Myths About the Food We Eat. Book number 1 in what might become a series. I would say that this is appropriate for even high school age kids. And actually not only appropriate, but probably very informative and might change their college outlook. Not that they wouldn't go, but I mean, they would make them look at the research and all the stuff they're about to learn in a much more reflective light.
You are not the first person to tell me that. And here locally, people have said, like, "Oh, you know what? This is something like, it'd be interesting to make it as part of like the reading for high school students." So sort of, as a gentle exposure to a lot of these issues of statistics and medical research, which is not something that people learn about in school. And it is, it's a fairly easy read. So if there's any teachers out there who want to make this part of their curriculum, hit me up. We'll make it happen. I think there is a definite value for this type of book for, like a grade 11, grade 12 type of population who are starting to sort of consume medical literature and be like, "Oh, what are the things I need to know about to keep track of to make me a more sophisticated consumer of a lot of the stuff I'm going to read on the internet."
Dr. Christopher Labos, epidemiologist, cardiologist, thank you so much for being here. You spent a great deal of time with me, all for the payment of whatever the royalties from 3 books are. So thank you so much. And hopefully you'll be back. We'll do another cardiologist update in a year. So
I'm in. You call me up, I'll be here.
all right. Thank you again.